I think you're probably right. The reforms currently being discussed here will not provide universal coverage. And maybe that's the answer to the question. But the efforts started out aiming to provide universal coverage and to achieve cost control. But at least the general view at the moment is that if it does achieve universal coverage or even comes close to it, it will not achieve much cost control. Indeed, by expanding coverage, it's going to increase costs. Now, is that because other parts of the reform program are not internally consistent with the scheme or consistent with what other countries do? Take what you said at the end one step further and apply it to the contemporary debate here.
Yeah, what I'm saying is if you leave 6 to 8% of your people uninsured, you don't get the economic benefit of universal coverage. You don't then have the political will to impose cost controls. If you have a fragmented system like ours that leaves 20 million people outside, then you still have the cost shifting, which is a serious problem in our system. And if you don't have a unified system that covers everybody, which we're not going to have with these bills, then you have the enormous administrative costs that other countries, they all have costs, but have managed to keep down. I don't know, does anyone here think of France as a paradigm of management efficiency? The French, 61 million people, they have 14 private insurance companies supplemented by a government plan, and their administrative costs are about 4.8%. American private insurers, our private insurers, they report to the Securities and Exchange Commission every quarter their administrative costs. They call it the medical loss ratio. They run 18 to 22%. I mean, that's a 20% tax on every doctor bill in America imposed by inefficiencies, which other countries don't have to pay. So, yeah, my argument is moving up slightly closer to universal coverage doesn't get you the benefit. Moving to a unified system that covers everybody, like the other countries have done, gets you the benefit. Japan's a good example. Japan got to universal coverage in the late 80s. And since then, their costs have been just about flat. You know, this notion that healthcare costs have to go up twice the rate of inflation no matter what? Actually, in Japan, from 1998 to 2006, healthcare costs went down, even though the results are great. And for the last 3 years, they've been flat. And, well, of course, inflation's been flat there, too. But, no, you get everybody in, and cost controls come along. I think that's clear.
Okay, the floor is open. Howard, please identify yourself and then fire away.
Howard Rosen here at the Peterson Institute. I've been frustrated by this comparison of how much countries spend on healthcare. Did you look at the differential in research and development that's done? Isn't it true that we do a lot more basic and applied medical research here, which gets included in that 14%, and our research is saving lives around the world, making it cheaper for healthcare in other countries?
It's true that we're doing great, innovative medical research that saves lives. It's not true that the other countries do not. As a matter of fact, a lot of really important innovations in healthcare have come from other countries with much lower cost structures. This is a key argument in my book. The notion that you have to pay through the nose or you don't have forward-looking research, I think, is wrong. A classic case for me is MRI scans. You know, the Japanese, as I said, they spend half as much per capita as we do on healthcare, but they have 3 times as many MRI scans. How do you do that? So I live in Denver, and I had to get a scan of the back of my neck on South Broadway at a lab at South Broadway in Denver. $1,234 it cost. 6 months later, I was in Japan and got exactly the same procedure, $105. 10,000, 9,800 yen. How do they do that? How do they do that? The reason is the government in Japan, the health ministry, keeps lowering the cost. As usage for a particular procedure goes up, they lower the cost, and that forces cost-cutting innovation. And the scan makers and the labs in Japan developed much more efficient means of doing the same diagnosis. So the United States definitely does groundbreaking research that's used around the world, but guess what? So do other countries with much lower cost measures. Really the only thing I think so far that anybody's come up with that seems to help with Alzheimer's disease and with depression is this deep brain stimulation, if you find the right spot in the brain. That's Canadian technology. Anybody in this room walking around on an artificial knee or an artificial hip, artificial joints is French technology. Even the drug industry's greatest achievement, Viagra, that's British. And the Brits are so proud of this guy, Richard Stennis, that the Queen knighted him for inventing Viagra. So, yes, we have great research and we pay for it. Other countries pay a lot less and also have groundbreaking research.
Just to stick with that one for a minute, because that comes up so frequently. First, the factual question. My impression is the United States is basically the only country, maybe one or two others, that does not have some kind of fairly tight price controls on pharmaceuticals. And if that's correct, then is it fair to say that U.S. consumers are subsidizing the rest of the world by paying higher drug prices, permitting lower prices elsewhere, and therefore we ought to put it on the agenda of the World Trade Organization and negotiate about it?
Yeah, it's 100% right. We are subsidizing drug buyers in all the other rich countries. Japan has per capita income slightly higher than ours. Those are pretty rich people. And they're paying about a third as much for the same pill as I do in the United States. You know why? Because I pay more to subsidize the Japanese. Do I want to do that? To me, that's a waste of my money. I don't think I should be doing that. But I don't know that it's a WTO issue. It's a U.S. government issue. I mean, if we use the buying power of our big buyers to impose, the demand power on the drug companies, I think we could, then they'd have to lower their prices in America and they'd have to raise their prices in other countries and we'd have less of a gap. In Japan, the health ministry sets the price for drugs. Lots of people sell drugs, but the price is set at the health ministry, and the ministry negotiates with the drug industry. It's the third biggest drug industry in the world in Japan. Every 2 years, they negotiate a whole range of prices, and the drug companies always bitch and complain, we couldn't possibly make any money selling it at this price, but guess what? They do, because it's the only market they've got. So if you use the buying power, you can get it. And since we don't use our buying power that way, with weak demand side, you're exactly right. We're subsidizing rich people in Switzerland, in Germany, and Britain, and Japan by paying too much or paying more for the drugs that they buy for a third of the price.
The reason I said WTO issue is because, as you say, you'd have to convince the health ministries in Japan and elsewhere to let those controlled prices go up to offset the lower prices here if we did what you said, if you believe that the pharmaceutical industry needs that total level of return to do the innovation as they claim.
Yeah, so if I'm the health minister of Britain or Japan, my answer to Fred Bergston is going to be, hey, I'm doing good economics here. I'm using my bargaining power to negotiate a good price. Why don't you? That's what I'd say.
Okay. Mac, and back in the middle.
First of all, thank you very much for both a great talk, and I'm a fan of yours from the chip onward.
Oh, how nice of you. Thank you.
Identify.
Mac Dessler Institute and University of Maryland School of Public Policy. You said there is not one road to success in this area, but there are a very wide range of models, and we're certainly learning in our healthcare construction, if that's what it is, that we're not starting from scratch, but we're kind of putting together and building on a lot of things, some of them good, some of them not so good, that are in our system. This leads to my question. Given where we are, or given where we might be, say, suppose one of these bills does become law and we have this new system in place, but we haven't addressed the cost issue very effectively, which seems likely. Which one of these systems, if you were to choose one, would you urge American policymakers to look at first, not just for its success, but for its relevance and usefulness for us?
Yeah, well, in terms of relevance, I'm assuming that we probably would most likely look to the Bismarck model countries, that is, countries that rely on private insurance companies. In the Bismarck countries, most people get insurance through the employer. They split the cost of the premium between the worker and the employer, and they get it from private, although nonprofit, insurance plans. The German model works fine, but in terms of cost controls and results, the Japanese model, it's not perfect, believe me. I mean, a lot of hospitals in Japan, the prices there are so low that hospitals are borrowing money for day-to-day operations from banks, and now they're in debt, hoping that next year the ministry will raise their prices a little, let them pay off their bills. But if we just look at Japan for a minute, it's the oldest population in the world, and by many measures the healthiest population in the world. Those two should not go together, but they do. Fantastic health results, huge consumption. They go to the doctor on average 15 times a year. We go 4.8. As I said, more scans, longer stays in the hospital, everything about it. Twice as many drugs, pills taken per capita as in the United States, and yet they spend half as much, a little less than half as much per capita. So that's a good model. And what they did in the Japanese model, they borrowed it from Germany. You know, they went around the world and just found good ideas for lots of things, for highways, for schools, for the Navy, for healthcare. And they borrowed that one from Germany, and they cover everybody. Basically, it's the employer's obligation, unless you're an employer with 10 employees or less, and then the local government takes over. The insurance plans are private, as I said. There are 3,000 different ones. But they really have imposed these strict cost controls. They shaft the doctors and hospitals, let's be blunt about it. And the result is fabulous results, no waiting, really good outcomes, and low prices. The problem in Japan is the population's aging so fast that they can't keep up, that even there they can foresee prices getting out of control. So 2 years ago, they imposed this tough new tax on seniors, and much higher premiums for people over 75. And guess what? The people over 75 went through the roof and rebelled, and the LDP gave in and took it all back. So at the moment, they have really serious financial problems. But as a system, it's working beautifully. So bring some of their ideas here. It's pretty American. It's a private system. That would be a good one to copy, I think.
Yeah, but Tom, just to continue on that, the economist's ears in the room will pricked up on two things. A, using 3 times as much, is there excess demand?
Absolutely.
Is it generated by the low price? And secondly, given what you said twice about how the hospitals and such are borrowing heavily and going into debt, is their system sustainable? Can the DPJ reject the next bid to raise the prices as the LDP did?
Sustainable is tough because they're not putting enough money in. They certainly don't want to raise taxes, and yet people don't want to pay more, as we saw with this plan for what they call the super old for people over 75. They got a lot of them. And I think I'll use that. Is there overuse? You're darn right there's overuse. If you look at this film I made, Sick Around the World, we're talking to a Japanese doctor, and I say, do you have some regulars? He says, oh, yeah, I got people come in every day. Are they sick? Oh, no. And the joke in Japan, I saw this on one of these late-night TV shows. Let's see. Hiroshi, Kiyoshi, and Kenji are sitting around in the doctor's office, and where they meet every day, and they have coffee out of the machine waiting to see the doctor. It's just where they meet every day. And Hiroshi says to Kenji, hey, where's Ichiro? Where's Ichiro? And they say, oh, Ichiro couldn't come to the doctor today. He's homesick. So they know they have an overuse problem. They're making jokes about it, but hard to fix.
Okay. I've talked to you about, yes.
Tom Donlin with Barron's Magazine. It seems like you're defining a success as something that is fine now, but can't be sustained. aren't you being short-sighted? And I think most of the economists in this room, at least, were taught somewhere in their career that price controls lead to shortages or black markets or both. And don't you find that? I mean, I'd be pleasantly surprised to see to understand where the lack of shortages is coming from.
I don't know much about economics, but I do know that's not true the case in Japan. In Japan, prices are really low. There is very high demand, as Fred said. And yet, the Commonwealth Institute, Commonwealth Fund in New York does these comparative studies. Waiting times to see a specialist or to get an appointment or to get surgery in Japan are shorter than in the United States. So far at least, they do have some shortages in rural areas. For some reason, all the docs want to go up to Tokyo and Osaka and live there. But other than that, no, they haven't had shortages. They have a shortage of nurses like every country does. Every country has that. So it's sustainable in these other countries. I mean, all countries, as I said, have a serious problem with dealing with rising medical costs. It's sustainable because what they're going to have to do to sustain it is go from 8% of GDP spent on healthcare to 9% of GDP on healthcare. That would be a huge boost to healthcare spending in Japan. They're probably going to do it. It's a problem we would love to have. If all we had to do was go to 9% of GDP to fix our problems, we'd be thrilled. So it is sustainable, but they're going to have to spend a little more money, but nothing like what the U.S. spends.
Okay, we got two back here. You decide.
I maybe get the microphone because I have in my hand.
Yeah, excellent. Discerning reader.
And our students at Georgetown really like to watch Frontline with you.
Oh, good. Thank you.
But this conversation so far has been talking about things like drugs and pharmaceuticals, and let's talk about people for a minute. I said in class only yesterday, it seems to me that we don't get enough doctors trained in this country compared to what we need. And one of the students said she's applying to medical school. At Georgetown University Medical School, they take 150 students out of 10,000 who apply. Of all the students who apply for medical school in the U.S., the same student reported to me, 60% actually get into school. 40% who apply, and presumably they are reasonable applicants, don't get in. In other words, we're blocking access to the top of the medical system in this country, and that seems to me at least one thing that one might like to address.
Yeah, I think that's an excellent point. Other countries have had this same problem. Canada made a terrible decision in the 90s. They had some commission that said they were producing too many doctors, and they actually reduced enrollment in their medical schools in the 90s. The result is they're now bringing in doctors from Africa and everywhere else because they have too few. One of the ways you deal with this is you build more medical schools, and that's happening out where I live in the Rocky Mountain West. Several states have recently added these DO schools. They're for-profit medical schools. We just got one in Colorado, and it's really going to help a great deal because we only had one medical school in the whole state. Another way to deal with this is what's called a physician substitute. And this is a trained nurse, a physician's assistant, somebody who hasn't gone through 4 years of medical school and 4 years of residency, but got a nursing degree somewhere and can handle a great deal of stuff. And we have tried this at various times, and quite often it's the local medical society that kills this effort. In Colorado, Walmart was going to have these clinics where you could go in for $4 for if your kid had a earache, and a nurse was going to give her a penicillin shot. And our medical society basically, the political system shut that effort down because these people weren't trained. So physician substitutes, I think, is an approach. Now, where are we going to get people who know something about the medical system who we might train to be physician substitutes? I can tell you a pool of 100,000. And these are the people who are currently underwriters at the health insurance companies. whose job is, A, to turn down people when they apply, which they're not going to be allowed to do anymore, and to deny claims. In all the other countries that have private insurance, the firms are not allowed to deny claims. They have to pay any claim submitted by a doctor or hospital. And I've mentioned this to the American insurance companies. Paul Krugman, the Nobel laureate economist, has argued that if they just paid every claim and didn't have to pay 100,000 underwriters, they'd come out ahead, right? The insurance companies say, oh my God, this would be a terrible time to throw 100,000 of our underwriters out on the street without jobs. So here's my argument. It's actually not my argument. Several economists have made this argument. We take these people who are already working in healthcare, they know some of the terminology, we give them a year or two of training in being physician substitutes and let them give the flu shots, put them out there. And then you don't have to wait forever to see your doctor, or if the nearest doctor is 3 counties over, you can have a nurse or a nurse midwife in your county. You see what I'm getting at? So a lot of countries have done this by this is widening the definition of a medical practitioner. And to make that work, you've got to get the medical community to agree to it. I think maybe they would.
Okay, your neighbor.
I'm Philip Musgrove. I'm one of the editors of Health Affairs. You've practically stolen my thunder because my question was going to be, isn't one of the things that we need a large income transfer from the insurance industry to the medical industry, which curiously the medical industry doesn't seem to have seized on. And we have the very weird situation that instead of government imposing prices, we have insurers making decisions that hold down the incomes of doctors. And you'd think doctors would want to get some of that for themselves. And I'm saying doctors, not necessarily these physician substitutes, although that would be part of it. There have been huge income transfers as the health sector has expanded up to 16, 17% of income. But there hasn't ever been one in this direction that says, why don't we make life a little easier for the people who deliver the care and a little harder for the ones who try to stop it? Has anybody made an estimate of that? I think we're probably talking about a good many tens of billions of dollars that need to shift.
I'd look to Health Affairs for those kind of numbers, frankly. Yeah, I think what you said, I had said, you said it more elegantly. Yes, we should transfer assets and money from the insurance part of healthcare to the treatment part of healthcare. I think that makes a lot of sense. And incidentally, since you're here from Health Affairs, somebody asked me whether we have to pay a lot more to get innovation. And Health Affairs just recently did a study about where new drugs come from. And lots of really valuable new drugs come from Europe and Japan. Isn't that correct? Yeah, they just did that story. So I think I really feel I nailed this one in my book. The argument that we have to pay through the nose or we won't have any groundbreaking research, I think is wrong. It's just, it just doesn't bear out. Yes, sir. In the back.
In the back, and then Rudy.
Thank you. Edward Peters from Open Connect Systems in Dallas, Texas. In your travels, have you run across anybody or any geographic places that are focusing on social networks and leveraging new internet technologies as delivery methods to help lower the cost and improve quality of the service to the overall population?
Delivery methods. No, I didn't see that. I bet it's happening, but I did not see that. What I did notice was, as I said, I took my sore shoulder to orthopedic specialists around the world. And when I went to the guy in Japan at Keio University Hospital, really distinct, the Johns Hopkins of Japan, that doctor was the only one who did this, palpated and looked at my x-rays and discussed my symptoms. And then he sat down and went on the computer to look up my condition and see what suggestions. The only one who did that. I was that made me feel good. I'm glad. Maybe he's not up on all the newest literature. But in terms of treatment, no, I didn't see that, but it may be happening.
Rudy?
Rudy Oswald, retired from the AFL-CIO. My question is about health care payments. The Senate seems to think that the only way that we can get cost control is to have co-payments, deductibles, and if workers and others only paid more for their health insurance, we would have cost control. Do other countries control their costs through this method?
So you're working on the assumption that there are different plans offering different packages, levels of benefits. Most countries don't have that. Most countries have designed a level of medical treatment that's available to everybody. And then in a lot of countries, you can buy supplemental insurance, we might call it Medigap, to cover stuff that's not in the private package. Botox, hair replacement, breast enlargement, stuff like that they don't cover. But it's a pretty small portion of every country's healthcare spending. Other countries just don't have the variation in plans than we do. The plans are all the same.
But if a worker goes to a healthcare plan, goes to see his doctor, does he have to pay 20, 30% of the cost?
Depends on the country. In Britain, their basic position is you should never in your life get a doctor bill. And 98% of the people in Britain go their entire life and never get a doctor bill or a hospital bill. They think that's normal. Same in Spain, Italy, a lot of Scandinavia is like that. In France, 25 miles away, they feel everybody should pay for every encounter with the healthcare system. If you go to a nurse with a hangnail, they charge you 10 euros. Then you get it back from the insurance company. But so a lot of countries have co-pays, and I asked them in France, why do you do this? Because in France, the co-pay when I was there was about 18 euros, $23, $22, and you got 80% of it back from the insurance company, usually within 3 days. So why bother, And the reason is they want people to know that they're getting something of value. So other countries have co-pays, but they're really low. Get this, in Germany, because Germany, like other countries, is really struggling with the cost of health care. So in 2006, are you ready for this? Fasten your seatbelt. The Germans instituted this reform, a co-pay, first time in history. It's a 120-year-old system. They instituted a co-pay, and everybody was up in arms. You mean that you got to pay to go to the doctor? This is outrageous. So the co-pay in Germany, are you ready? It's 10 euros, that's $15, which you have to pay once a quarter. And then everything else is free. And the doctor that I spent time with, a lovely doctor as you can see her in our movie, told me, she lives in Kladow, which is a charming town south of Berlin, and there are several American expats living there. It's a nice place to live. And one of her American clients came in to see her with something in January of 2006, and she said to him, "Oh, Bruce, I'm sorry, but now you have to pay a copay for the first time." And unlike the Germans, he didn't complain. He just gave her the 10 euros. That's fine. And then she says to me, and that American, he came back to see me for something else in March, and he tried to pay again. She says to me, "Do you have to pay every time you go to the doctor in your country?" Some of them have copays, but they're low. They're much lower than in America. Yeah.
Hi, Tom. Jonathan Rausch, National Journal.
Oh, hi, John.
Nice to see you again.
Very
We
nice
last
to
saw
see
each
you.
other
Hi.
in Japan in 1990 when all the Americans I talked to said, whatever you do, don't get the flu in Japan. You will be hospitalized for 6 weeks and have 10 medications given to you because that's how they will make money in the system over there. At the other end of this scale, could you comment on the frequent suggestion that setting the payment and efficiency issues aside, if you're really, really sick, you definitely want to be in America?
Well, even if you're not really sick, if I had some ailment, I'd like to be in America. You know why? I got good insurance. Some Americans get the best care in the world in the finest hospitals with no waiting. I'm one of them. I have no complaint about American health care. The problem with our system is not good care for some people. It's the fact that tens of millions are left outside the door. That's the problem. But it's definitely true that I hear that, look, I'm selling a book. I'm on right-wing radio all the time. And what I hear is Arab sheiks fly to the Mayo Clinic. Why would they do that if we didn't have the best health care in the world? Yeah, if you can go to the Mayo Clinic and pay out of pocket, you're going to get the best health care in the world. There's no question about that. And many Americans do, and I do, because I have good insurance and I'm on the board of the University of Colorado Medical School. All those things add up, But the problem with our system is not me or you. It's the tens of millions of people who really don't have access until they're really sick.
Well, the implied argument is that we will lose the high-end medical care if we go with a kind of universal one-size-fits-all program.
Yeah, that hasn't happened in other countries. I haven't seen any place that went to universal coverage and saw a decline in the quality of care. I don't see. I think if we went to universal health care in a 2 or 3 year period, we'd definitely have a shortage of providers, as we said, for the first 5 years until the system or the market met this need. But other than that, I don't think improving health care for the 40 million without insurance is going to hurt the rest of us who have good insurance. And may I just say, I don't understand the argument that increasing health care is going to take away from Medicare. I don't quite see why that would be. I just don't see that argument. I know because I've been reading some stuff from the birth of Medicare in '65, and Wilbur Cohen argued that if we gave Medicare to our seniors, they would see that it worked, and they'd want it for their children and grandchildren, and eventually everybody would be on this kind of system. It's been the opposite. It's the seniors who are the least willing to extend care because they seem to think it would undermine their treatment. I don't get that. But anyway, I haven't seen that in any country. Now, all the countries that went to universal care, I haven't seen any degradation. You get a huge improvement in overall population health, obviously, because a lot of people who weren't treated are being treated. And I haven't seen any sign that people at the top have degraded care. I just don't think that's true.
Tom, we're getting close to our witching hour, but I want to come back maybe with a final question to where you started on the philosophy and ethics of the issue. Everything you have said has applied to rich countries.
Yeah.
Your whole universe of analysis and research and writing has been on high-income countries. But poor-income countries account for 80% of the world's population or more.
Yeah.
So, does the same philosophical argument apply? Does it simply run into practical financial limitations? Did you do any thinking about how all this applies to poorer countries and how they should be brought into the kind of system that you talked about as being a basic human right for the rich? And if so, why not for the poor?
Basically, the answer to that is no. I was looking for two things. I was looking for models to fix American health care, and I was looking for a way to fix my bum shoulder, and that kind of dictated rich, advanced countries. But I do, in my book, spend some time looking at the developing nations. That's another model that I didn't mention here, but the model for healthcare in those countries is called the out-of-pocket model. And basically, if your child is sick and you have some money in your pocket, she gets treated. And if you don't have any money, she stays sick or dies. That's the system in 150 countries in most of the world. I didn't look at how to extend health care benefits to people in those countries. It just wasn't my topic. But what we have seen, and we do see in my book, is as countries get rich, the countries that you wrote about, these East Asian tigers, for example, many of them decide that as a rich country, they ought to provide health care to everybody. They feel this moral obligation. A classic case, which I describe in some detail in my book, is Taiwan. Taiwan went from about 40th in the world in per capita GDP to 11th or 12th in a period of 20 years. It was a rich country. And in 1994, they said, hey, we're a rich country. We need a rich country's healthcare system that provides healthcare for everybody. And they did it. And I like Taiwan myself because they did what I did. They went around the world and looked at all the successful systems and chose one. They chose the Canadian model, which I described to you earlier. So as countries get rich, they do move to universal coverage. But no, this is a luxury in the third world. I mean, they're having enough trouble with food and shelter. Healthcare is a luxury in those countries. So I mention in my book, India is about 1.2 billion people, and roughly 500 or 600 million of them will never see a doctor in their whole life. You know, they might see a village healer, but not a medical doctor. So, no, I don't deal with the third world, but developing countries, because I was looking for models for the United States. But maybe if we got to universal coverage at a reasonable cost in the U.S., then we could steer the developing world to that goal too.
Well, Tom, we thank you enormously for sharing your thoughts with us. I will certainly advocate everybody buy the book, read the full text, and I'm sure be hearing more from Tom as he presents it in lots of forums, TV, radio, and elsewhere as the debate goes forward. Tom, we're enormously in your debt. Thank you very, very much. Thanks to all for coming.